Okay, hopefully everyone can hear me. Um, well, my name is Johan Garschen. I'm professor immunology at Utrecht University, but also in part working together with nutrition research on specialized nutrition. I'm extremely proud and happy that you decided to join this very special educational webinar. It's all about the secrets of the best nutrition there is, which is breast milk for young kids, and also about unraveling the myths and facts related to breastfeeding and COVID, which is of course a very hot topic nowadays. Well, to start this very special seminar, I would like first to introduce our two speakers. The first one is Maria Carmen Collado. She received her PhD in biotechnology from the Polytech University of Valencia in the south east of Spain. Now she is since 2007 already adjunct professor, but also in part connected and working for the University of Turku, which is in the southwest of Finland. And still keeping her research scientist role at this Department of Biotech in Valencia. So it's really great to have Maria in this web meeting, web conference. Her work is very multidisciplinary. There's all kinds of disciplines linked to microbiology, immune health, food science, nutrition areas, infants, toddlers, pregnant, lactating women. So really multidisciplinary, and it's really great to have Maria in this webinar. Following Maria's presentation, we will move to Sarah Jarvis. She is from the UK. She is a real general practitioner, so medical doctor, working in a very special area in London, Shepherd's Bush. But it's really unique. She's also pretty active in mass media to promote health. She is even a health and medical reporter for The One Show, a regular guest on BBC Radio 2, clinical consultant for health website Patient UK. And because of all her fantastic work, she was awarded an MBE, which is something like a royal award in the UK. It's an honor to have her in this webinar as well. So knowing a lot about the general practice, understanding public health, etc. So really great to have these two top speakers in this webinar, and I'm really proud that they are both willing to do this in order to inform and discuss this highly relevant topic. It's all about human milk, immune health, early life in connection to COVID-19, which is a real health problem nowadays. So just a few slides to start. As I already said, I do have some sort of double position. I'm a medical doctor and PhD in immunology, heading the pharmacology department at Utrecht University, but I'm also responsible for immunology research within nutrition research in the Netherlands. Well, as said, for today, it's all about early life immune development. And what I said in the second sentence, it's about the gateway to health, because please realize, when something goes wrong early in life, it might have consequences for the rest of your life until, let's say, even 100 years of age. Yeah. Next slide, please. You can skip this one. I just explained that. So having two roles. Well, the immune system is essential. It's involved in almost all diseases and health aspects we think of. This is just a picture from a textbook. You can see there are many organs involved. It's about lymph nodes. It's about the spleen, patches, appendix, bone marrow, with lots of cells. It is also explained that it's pretty difficult to analyze and to understand this whole system. But just in a nutshell, please realize that this is something like our sixth sense organ. Yeah. So taking care of our body. Yeah. So when dangerous pathogens such as corona, COVID-19 is coming in, this immune system is needed to kill these awful pathogens. But it's also needed to induce what we say immunological tolerance. So just try to stop immune reactions against safe food. Yeah. So that's all about tolerance. It's also involved in response against cancer cells. Realize that all of us do have cancer cells in our body, but thanks to a very efficient immune system, our sixth sense organ, these cancer cells are removed and wiped away. Let's go to the next slide. The immune system is essential. You know, it started to develop already in utero, but what we think now is that especially during the first 1,000 days of our life, there are many changes, many changes that are key and essential to keep our body healthy, not only during these first 1,000 days, but also the rest of our life. And this is just one figure that is published in different journals, showing that some organs are really key. And the upper one, the thymus in this graph, is one of those most important immune organs early in life, aimed at training and educating a healthy, balanced, resilient immune system, essential for health during the rest of our life. Next slide. Yeah, what was really unique and something that I was not realizing when I was studying medicine in the 80s, that the gut is an important part of our immune system. You know, the old textbooks for immunologists, medical doctors in the 80s was even not talking about the gut as an important part of our immune system. But now we realize that a significant number of our immune cells are localized in the gut, which is logic, since our food is not sterile. So you need an efficient immune system in the gut in order to get rid of all these awful dangerous signals and pathogens entering our body via this gastrointestinal tract. Adding to that, there is more and more knowledge indicating, explaining that we have lots of neurons, and maybe even more important, incredible number of microbes, yeah? And the interaction between these different systems, between these different circles in this figure is explaining now that, you know, gut and the food are key to keep our immune system healthy in terms of prevention, but also in terms of management of all kinds of immune-related disorders, such as allergies, infections, autoimmunity, and so on. Next slide. So just in a nutshell, and this is the last slide, there you see the word immune resilience, yeah? A fit immune system. This is a wording that is nowadays accepted and even positioned by, for example, the World Health Organization. It refers to an inbuilt capacity to adapt to challenges by establishing, maintaining, and regulating an appropriate immune response. So on the short term, this is essential to create tolerance against safe foods, but at the same time, to protect ourselves against all kinds of awful, dangerous signals, such as awful pathogens coming in. At the long term, a balanced, resilient immune system is essential to protect ourselves against so-called non-communicable diseases, such as cancers, autoimmunity, allergies, asthma, etc., etc. So both at the short term and long term, immune resilience is one of these key factors that is induced for a significant part during the first 1,000 days of our life, keeping us healthy now, but also later in life. So this is in a nutshell why I believe that the immune system, and especially early life, is so important for prevention of all kinds of awful disorders earlier and later in life. Well, after these introduction slides, let's move now to the presentation by Maria Carmen Collado, again from Spain as well as Finland, and she will talk about the magic of breast milk and its role in the development of the gut microbiome, microbiota, and immune system in early life, with relevance for health later in life. So please, Maria, the floor is yours. So let's try to start up. Yeah?
Hello, my name is Mari Carmen Collado. I'm working in the National Research Council in Spain, and I'm going to talk about the magic of breast milk. The outline is about the breastfeeding, the relevance for maternal infant health, the relationship between microbiota and immune system, what is in breast milk, talking about nutritional aspects but also bioactive components, focusing mainly in prebiotics, probiotics and postbiotics, which are the factors that can shape the milk composition, and then the conclusions. We know that the lactation is a hallmark feature of the mammals. Breastfeeding provides the optimal source of nutrients and also support the neonatal requirements and infant growth and development. We know that breastfeeding further exerts beneficial effects for the infant, also exerts benefits from both mother and infants. For example, in infants at short term, the breastfeeding protects against gastrointestinal and respiratory infections. Also, breastfeeding practices are able to reduce the risk of allergies, necrotizing enterocolitis, and also sudden death. In long-term effects, breastfeeding protects from overweight, obesity and diabetes, low pressure, cholesterol, and also it's related with behavior and neurodevelopmental outcomes. But also in mothers, breastfeeding exerts benefits because mothers had better postpartum recovery, they had lower risk for postpartum depression, and important thing, the mothers have lower risk of breast and ovarian cancers and osteoporosis and as well diabetes type 2. We are going to talk a little bit more about the breastfeeding protection against infections. We know that the lack of exclusive breastfeeding among infants from 0 to 5 months of life are associated with an increase in diarrhea mortality and also in pneumonia mortality, but also in the morbidity of both diseases. In a recent study, the researchers with more than 6,000 infants observed that the breastfeeding practices protects against the infections, respiratory infections, and also gastrointestinal infections. But also breastfeeding, what happened with the breastfeeding during the maternal infections? There is limited medical conditions in which breastfeeding is contraindicated, just with few views, including HBI. The potential routes of transmission of respiratory secretions and droplets, direct contact with the lesions in the breast and the nipple, and breast milk per se. However, the risk for transmission from the breastfeeding practices should be discussed always with the clinicians and balanced with the benefits of the breast milk. In this table, you can see some recommendations for breastfeeding practices during the maternal infections. Mothers should not breastfeed with specific diseases. Mothers should temporarily not breastfeed if they have specific problems, as you can see in the slide. And mothers should temporarily not breastfeed, but can feed express breast milk also under certain circumstances. Breastfeeding. Breastfeeding or breast milk is the gold standard for infant nutrition. Early infancy is a critical window of development where the food is important for the adequate growth and development of the neonates. World Health Organization recommends exclusive breastfeeding for the first 6 months of life, and then continue the breastfeeding, including complementary food, up to 2 years and beyond. Breastfeeding is important because modulates the neonatal microbiota and environment. Breastfed infants has been shown to contain higher levels of bifidobacterium in their gut. And this bifidobacterium has been known as a hallmark of the infant microbiota. But also recent studies are showing that the breastfeeding also modulates the environment. Bacteria, virons are evolving through the breastfeeding in the same time that the immune system is being developed and is going to be mature. The key relationship between microbiota and immune system is key for promoting health. Bacteria present in the gut is interacting with the specific receptors in the immune system. We can distinguish 2 main lines of the interaction between gut microbiota and immune system. Defense against pathogens, but also development of the immune system in early life. In the area of defense against pathogens, we know that bacteria can produce some antimicrobial peptides, can compete for nutrients, adhesion sites, and can inhibit the growth of specific microbes. The microbiota can also stimulate the immune system through the production of IgA, and also can influence the development, structure, function, and of the epithelial barrier. These microbes are promoting the homeostasis in the intestinal gut. But also, these microbes are helping to develop the mucosal innate immunity in infancy. are producing some metabolites which can regulate the cell development and activation. And also these microbes are helping to develop the adaptive immune system by signaling specific lymphocyte subsets and also to establishing the ratio T1 to T2 effector cells, which determines the systemic immune response. But what is in breast milk? We know that breast milk is totally different in composition in different mammals. We can see that the composition in humans in terms of macronutrients, water, fat, complex oligosaccharides and proteins differs from human milk to cow's milk and also to seal and rabbit seal. And also is related, the protein content is related to the weight development. Furthermore, beyond the nutritional aspects, breast milk contains a huge spectra or wide range of bioactive compounds. In this slide, I always love to include this slide because in one picture you can see all the different components that can be identified in the breast milk compared to the components that can be identified in the infant formula. You can see the comparison is totally different. Thanks to the analytical development and the new methodologies, we are getting more information about the composition of the breast milk. And this is promoting the better standards and highest quality control for the infant formulas. Then we need to learn about the nature. We need to learn about what is in breast milk. In brief, we can say also that the human milk is a model to modulate the microbiota and immune system. Why? Because there are specific compounds like cell constituents, proteins, but also other bioactive compounds like bacterial metabolites, bacteria, and oligosaccharides that have a specific effect at the immunological level. For example, promoting the tolerance, promoting the maturation of the immune system, and also promoting an adequate microbial colonization in the neonate. Other compounds, like fatty acids, protein, carbohydrates, minerals, and vitamins are mandatory in infant formula. But what about the bioactive compounds? We know that the prebiotics are substances that are selectively used by the host and by the microorganisms, conferring a health benefit, while the probiotics, they are live organisms which, when administered in adequate amounts, colonize the gut and exert beneficial biological effects. When we combine probiotics and prebiotics, the name of the definition is symbiotics. But what about the new terminology on postbiotics? What are the postbiotics? Postbiotics are a mixture of complex compounds like bacterial fragments, lipids, carbohydrates, vitamins, organic acids that are produced by bacteria during the fermentation. And also these include non-viable cells. We are going to talk a little bit more about these compounds. What are the prebiotics in milk? Human milk oligosaccharides are a family of structurally diverse and conjugated glycans that are highly abundant in and unique in human milk. There are more than 200 different oligosaccharide structures. 2-fucosyl-lactose is the most abundant, and the composition of oligosaccharides changes in profile and in quantity during the lactation. The interesting thing is that these oligosaccharides are not digestible for humans. Then who is using the oligosaccharides? The bacteria. The factors that can affect the oligosaccharide profile are different ones. For example, we know that oligosaccharide profile changes through the lactation from colostrum to transitional milk to mature milk. But also, it is well known that oligosaccharide profile is influenced by the genotype, by the gene of 2-fucosyl-lactose, 2F, the FUT2 gene. As you can see, there are differences in secretor that they are positive for this FUT2 gene and non-secretors which are negative for the gene. Also, Lewis group influence the profile of oligosaccharides. In this slide, you can see differences in colors, and colors means or represent different oligosaccharides. You can see that non-secretor profile didn't have red color, and this is because 2FL is not present in non-secretor samples. What about the functions? What they are doing in the gut? Well, we already know that the oligosaccharides can promote the growth of a specific beneficial bacteria, but also oligosaccharides are related to anti-adhesive and antimicrobial compounds. They also are related to the immune system. They are related to the antigens in the mucosal system. Also, they are immune modulators because they are able to modulate the Th1, Th2 response. They're also promoting the T regulator cells. The oligosaccharides also modulate the leukocyte rolling and adhesion, and there are more activities beyond the gut because oligosaccharides has been suggested to active in the brain development as well, and in the neurodevelopmental normal development in the neonates. What are the probiotics in milk? Is the next component that we are going to talk. Human milk is a constant source of the microbes. Culture-dependent and independent methods allow us to identify a huge spectrum of bacteria. Of course, the new technologies, including the high-throughput sequencing, increase our knowledge. The evidence shows that the bacteria present in human milk belongs to Staphylococcus and Streptococcus genus, followed by Bifidobacterium, Lactobacillus, Enterococcus, and other bacteria. The quantity of these bacteria present in milk is around 10 times up 4, 10 times up 5 cells per milliliter. And about the functionality, these microbes promote the structural development of the intestinal gut. Also, they have a metabolic activity because some of these bacteria can produce bactericins and antimicrobial compounds, specific metabolites that can interact with the specific receptors in the gut, and also protector activities because they are adhering in the intestine, they are competing by nutrients, and they protect against infections from outside. But also the presence of microbes is not unique in humans. Other mammals' milk, like cow, pig, donkey, and goat, also contains different bacteria in raw milk. There are many factors that can affect the human milk microbiota: maternal diet, gestational age, lactational age, antibiotic use, environment, etc. Indeed, we and others than we analyze the different factors that can affect the human breast milk composition. And interestingly, the maternal body mass index and weight gain affects the microbiota composition in milk. The mode of birth, mode of delivery, mainly because the use of antibiotics that reduce the diversity and the composition of bacteria. The gestational age, preterm milk microbiota are totally different than term milk microbiota, maternal infection, and feeding methods, pumping and breastfeeding, and also the gender influence the breast milk composition. What about the metabolites in milk? What do we know about them? We have some data in which we compare the metabolite profile in different countries. We compare breast milk metabolite profile from China, from Finland, from Spain, and also from South Africa. And in this slide, you can see how different colors are totally clustered in different areas. Each color represents a different country, and you can see how there are differences in the metabolite profile according to the location. But at the same time, other international groups publish similar results than us in different cohorts. They include Japanese, US, Norway, and also Australian samples. And also they found that the environment, the location, shapes and modulates the breast milk metabolite profile. In our data, we found a really huge spectra of different metabolites in milk. We detect amino acids and the derivatives. We identify energy-related metabolites. We identify as well neurotransmitters, growth factors, and other compounds, fatty acids, associated metabolites. We also found sugars and other compounds, and vitamins and nucleosides. Interestingly, we found specific microbial origin metabolites like butyrate, putrescine, and epurate. And we were trying to identify if there are some relationships between these metabolites and the breast milk microbiota composition. And the answer was yes. As you can find, or you can see in the heat map, different bacteria were related in a different way with a specific metabolites. Then also we identified that the complexity of the human milk is linked with microbes, oligosaccharides, but also with the immune microbe profile, like cytokines, growth factors, etc., present in breast milk, but also with proteins and peptides and fatty acids. Then the magic of the human milk is this complexity, different compounds, macronutrients, and also bioactive compounds, and how specific factors like lactation stage from colostrum to mature milk, environment, maternal diet, time of the day, medicines, all these things would also shape the composition. This is the magic of the human milk. Just to finalize, specific take-home messages. Human milk is the best nutrition for newborns and has been shown to support optimal growth and development of infants. We know that breastfeeding has positive effects for both mothers and infants. Human milk has a complex orchestral composition, providing among other nutrients, bioactive components like oligosaccharides, immune cells, microorganisms, and their metabolites. Oligosaccharides are acknowledged to play a crucial role in the development of gut microbiota and immune system, promoting the growth of specific bacteria, but also interacting with the immune system. Milk microbiota and their metabolites are hypothesized to play as a role in the development of the gut microbiota and immune system, because the breast milk microbes are supporting the initial microbes that mothers transfer to the babies at birth. And we know little on the breast milk microbiota, then for sure we need further studies and further information about specific compounds and the specific biological influence, impact on the neonate with effects in their health at short and long term. Thank you very much to all of you.
Okay,
Hello.
well,
I'm ready.
Okay. Thank you, Maria, for this wonderful, educational, insightful session. It's really nature's miracle, this human milk, and you know, from myself, from a pharmaceutical environment, it's nowadays the example of a multi-targeting concept, which is not a concept anymore, since it's already there. And what we should realize that hopefully all babies on our globe will have access to this miracle, but that's not always the case. But again, thank you so much for this wonderful
Thank you.
talk. It's always difficult to how to do this, because it's all digital. So yeah, so we can still improve, but you did a great job. In the meantime, some questions are coming in, and the first question is, you know, Maria, that there are companies like Nutricia having oligosaccharides in their products, and a famous mixture of oligosaccharides is this GOS-FOS, so galacto-fructooligosaccharides in a 9:1 ratio, in order to mimic as far as possible the human milk oligosaccharides, although it's not similar. So what is your vision? So this is a question from the audience. Is this Gosfos better than the new concepts that are reaching the market now containing 2FL? Since 2FL is the highest level of oligosaccharides in human milk. So what is your vision there? What is your idea?
Well, thank you very much for asking me this. I think this is not an easy question with a black and white answer. But from my point of view, if we compare with the human milk, as I already mentioned in my presentation, contains more than 200 oligosaccharides. And different oligosaccharides have different targets in the intestine, and maybe they can exert as prebiotics for different bacteria. Then if we compare with just one or single oligosaccharide, I mean, the diversity is less. Maybe just one type of bacteria or one type of specific immune components and immune pathways would be active, while maybe a mixture of different oligosaccharides, as is being done with GOS and FOS, maybe also provide this diversity that is included in the breast milk. Maybe I'm not clear, but I think in the diversity, we have the key.
Yeah. Do you think or feel or have any data that the diet of the mother can influence the type of oligosaccharides or the level of oligosaccharides or maybe other immune modulating ingredients in this milk?
Mm-hmm. Yeah, well, there are many data showing that maternal diet would affect the macronutrient profile in human milk, mainly the fat and protein profile. There are also recent data showing that maternal diet, mainly high fiber intake or high fat intake, would also affect the immunomodulatory components. For example, high fat is related to high pro-inflammatory components in milk, but also is linked with other composition. We already sent to publication a work in which we find that maternal diet also shapes the breast milk microbiota. We found that mothers with better diet in terms of higher fiber, fruits, and vegetal protein intake had higher diversity in their milk, and this is reflected in the neonate. And for example, there is another study that was published in US that probiotic consumption would affect the oligosaccharide profile. Then I think the research is quite open in this new field, and we are going to get new data about how maternal diet or how specific nutrients in maternal diet affects a specific compounds in breast milk.
Another question is coming in, Maria.
Okay, yes.
At the beginning of your story, you explained very nicely the difference between probiotics, so the living microbes, the prebiotics, the food for the microbes. But then there was a third one, which is postbiotics, so products, the metabolites from the microbes fermenting the oligosaccharides. So are there postbiotics present in human milk? And if so, what is the function of this group of molecules?
Well, good question. In my presentation, and I mentioned that we can find microbial metabolites in milk, and postbiotic definition, even there is not a consensus yet, but I know that there are organizations that are working in the official definition. We can find microbial metabolites in human milk, and also we can find bacterial cells alive and also non-active in human milk with a specific targets in the neonate. What are the specific functions? For example, butyrate present in human milk maybe have the same functions than in early life or adult life. This butyrate can be the source of energy for the epithelial cells. For example, other compounds can help to stimulate and to interact with specific receptors in the intestine, activating specific signaling and helping to the maturation of the neonatal intestine. But of course, we need also to get more information about the specific postbiotics and the specific functions.
Yeah. Well, Maria, there are much more questions coming in. We cannot answer them all because of time, but I promise you that we will try to organize that some of these questions will reach you after this webinar meeting, because I do see a really interesting question, but we have to continue. So thanks again for your wonderful talk and this Q&A session. There will be a second poll question now appearing on your screen. Yeah. So I hope that this is really true. Yeah. So the clinical manifestations of COVID-19, so the coronavirus, in pediatric patients are generally less severe than those described in adults. Is this true or is this false? So please give your answer. Yeah, I'll wait for a few seconds and then we'll move forward. Now we will move to our second speaker from the UK, Sarah Jarvis, and her presentation on COVID-19 during pregnancy and breastfeeding. What are the latest insights, practical tips from science and practice? A very important topic, since we all know that this COVID-19 is all over our globe. So we need to know more about it, especially for those that are feeding the babies and those that are pregnant. Science is going very, very fast. Almost every day new info is coming out. And again, as said earlier, I'm really, really proud that Sarah is willing to give a presentation on this topic. Yeah? So Sarah, the floor is yours.
Hello, my name is Dr. Sarah Jarvis, and I'm here to talk to you about COVID-19. I know we've heard a lot about it, but I'm a GP in the UK and a medical broadcaster, and I've spent a great deal of time in the last 2 months talking to the public and, of course, to my colleagues about the implications of COVID-19, both for the general public, but also, of course, importantly, for pregnancy and breastfeeding. I'd like to share with you, therefore, some of the latest insights. So let's just start with a little bit of background. Let's think about where COVID-19 came from. Coronavirus is not a new virus in itself. We know a lot about coronavirus. Indeed, one form of the common cold is caused by a coronavirus. There are 7 types of coronavirus, including SARS-CoV-2. We'll call it COVID-19 from now on because, of course, it has several names. But this is the 7th one, which has been identified as being capable of infecting humans. The first one that we all became very worried about was the SARS virus. That, of course, is in fact officially SARS-CoV-1. That was first recorded in 2002 and again came out of China. To put it into perspective, overall, while there were real concerns about a pandemic at the time, it infected a total of about 8,100 people, and there were about 774 deaths. It had a mortality rate in the region of 10%. A far higher mortality rate was seen with the next coronavirus, which was able to infect humans. That was the MERS virus, the Middle Eastern Respiratory Syndrome virus. That emerged in about 2012 in Saudi Arabia, and it had a mortality rate of over 35%. So it was a much greater concern. However, given that it had almost exactly the same number of deaths, as you can see, we can understand that the number of cases was much, much smaller. However, in both of those, and indeed in COVID-19, we see a similar pattern emerging. All 3 appear to have arrived from bats via some sort of animal vector. In SARS, there was an animal vector, possibly at a wet market in Wuhan, and in MERS, the vector was the camel. SARS-CoV-2, the cause of COVID-19, was first documented in December 2019, and the World Health Organization was made aware of it on New Year's Eve 2019. It's extraordinary to think that we are now only in the first half of 2020. Look what's happened. Worldwide, the figures I have date from the 25th of April, so clearly they'll be higher by now, but nearly 3 million people have had confirmed cases. That is a dramatic underestimate of the total number of people who have contracted the virus, a dramatic underestimate, because of course in many countries there are different criteria for testing, but very often it'll only be the most serious cases who are tested. And of course there is a worldwide shortage of testing reagent and swabs for PCR testing. But worldwide there have been 198,000 deaths as of the 25th of April. And of course, again, even that may be an underestimate, because in certain countries, particularly the emerging countries in Latin America and indeed in India, it can be very difficult to record the deaths accurately. So, what are the symptoms? Well, generally the ones which we most look out for are fever and dry cough. There have been a very large number of other symptoms, which you can see there on the screen. But on the whole, those tend to be seen in association with either fever or dry cough. And that's why in the United Kingdom, those are the two key symptoms which we look out for. The cough tends to be dry to begin with, but may often become more purulent later with sputum production. Fatigue is a very major factor, a prominent feature for many patients, and unfortunately, it may well be that going forward, we're going to see a lot of people affected with ME-type symptoms, myalgic encephalomyelitis-type symptoms, or chronic fatigue syndrome, as it's often known, because we are seeing a lot of people with profound lethargy following their apparent otherwise recovery from the virus. Shortness of breath tends to be a later feature, and on average, many patients with mild to moderate symptoms, if they are going to go on to develop more severe symptoms, will develop those in the second week. Myalgia and arthralgia, again, a very common feature. But sore throat, although it happens, it's not nearly as common as it would be with, say, a rhinovirus. Why is there a concern then about pregnant women? Well, overall, the mortality appears to be much, much higher in older patients. So among over 80s, the mortality is probably in the region of 10%. But among younger people, and particularly young healthy people with no underlying condition, there has not been nearly as much concern. The other group, of course, who are at risk are people with underlying health problems, hypertension, heart disease, diabetes, conditions which suppress the immune system, and so on. But we do know from previous viruses that although pregnant women may not be more susceptible to catching an infectious disease, the immune system, particularly in the last trimester of pregnancy, may well change. And as a result, there may be much more severe conditions associated, possibly as a result of an immune response rather than as a result of the infection per se. So these are the experiences that we've seen with those other viruses. Influenza, there was an Australian review of H1N1. There's a significant increase in critical illness among pregnant women. With SARS and MERS, we've seen that increase tends to occur in the last trimester of pregnancy. And certainly there's been at least one case study, and don't forget, in relative terms, the number of total cases of SARS and MERS were extremely small, only in the region of perhaps 12,000 in total. So even among those, we did see an increased risk of preterm birth indicated after 28 weeks gestation. So let's look then at SARS-CoV-2 COVID, coronavirus, or the one we're all worried about. There is reassuring news thus far. The relative numbers, of course, are still fairly small, but given how many people now have been affected worldwide, I think it's fair to say we're getting a reasonable picture of what people can expect. And thus far, there is no data suggesting increased miscarriage, no data suggesting increased early pregnancy loss, and no evidence of teratogenicity. And this and much of the other data in this presentation comes from a very comprehensive review performed by the Royal College of Obstetricians and Gynecologists in conjunction with the Royal College of Midwives. So again, it's later in pregnancy that we are getting more concerned. This was a systematic review of 108 pregnant women who did have coronavirus. 20% of them were in the first and second trimester, so let's not forget that these were patients with more significant disease. And I think that probably reflects the fact that, as per the previous slides, there is little evidence of more severe problems in the first trimester. So many women, of course, will not have been diagnosed in the first trimester. So of these hospitalized women, 80% were in their third trimester. The presenting features were perhaps as one would expect. Nearly 70% of them had fever. More than a third had cough. In terms of blood parameters, lymphocytopenia was prominent in 60% of cases, and perhaps not surprisingly, an elevated CRP was seen in 7 out of 10 patients. Now, of those patients, more than 90% were delivered by caesarean section, but it is very important to remember that we do not have full data as to the rationale for those deliveries. It is possible that a decision was made on the basis of maternal and perhaps infant best interest without necessarily having fetal distress, or indeed without the mother being critically ill, that caesarean section would be appropriate. There were 3 maternal intensive care unit admissions, but in this selection of 108 patients, there were no maternal deaths, 1 neonatal death, and 1 intrauterine death. And again, it's not 100% certain whether those related to coronavirus infection or whether they were incidental from an unrelated cause. If we then look at a much bigger selection of patients, but not all pregnant, this comes from the UK Intensive Care National Audit and Research Centre. And these are the figures up to the 10th of April. These are the most recent figures we have. We've had almost 4,000 patients admitted to critical care settings, to ICUs. Of those, only 0.26% were pregnant. So that's a significant underrepresentation compared to the number of women in the population as a whole. In addition, there were another 0.33%, 13 women who had been pregnant within the last 6 weeks. But interestingly, if you then compare the rate of non-COVID viral pneumonia in the preceding 2 years, the incidence was not that different in terms of numbers admitted to critical care. And other reported cases of COVID-19 pneumonia in pregnancy do appear to be milder. These were women who weren't admitted to critical care units, and they do appear to show good recovery. So far, so good. What about passing on vertical transmission of COVID-19 from a pregnant woman to her unborn baby? Well, all we can say is, I'm afraid, maybe not. We're not quite certain. Until fairly recently, there had been significant numbers of studies done of pregnant women, particularly in China, and amniotic fluid, cord blood, neonatal throat swabs, placental swabs, genital fluid and breast milk samples from COVID-19 infected women and their babies all tested negative. So we felt reasonably confident, and indeed the earlier versions of the RCOG, Royal College of Midwives guidance, suggested there was no evidence of vertical transmission. Now, there had been 3 cases of raised IgG antibody levels and of raised cytokine levels at birth. However, it is important that there is cross-placental transfer of IgG. The same cannot, however, be said of IgM. So IgM does not cross the placenta, and therefore there was significant concern following 2 cases, 2 reports studied, of IgM present in neonatal samples. However, doubt has been cast even on these. The sensitivity and specificity of IgM varies by disease, but they do tend to be less reliable than other molecular diagnostic tests, and the levels of IgM dropped very, very swiftly, much faster than expected. So there has been some query as to whether, in fact, that was either a false positive or placental transmission. So, what does that tell us? Well, what it tells us is that overall, women do not need to be unduly concerned, although they should be more concerned in the last trimester, and that every woman should be taking steps to protect her from herself from coronavirus. The majority, of course, of transmission of COVID is via either droplet spread or by fomites, contaminated surfaces. So social distancing, 2 meters at least, possibly more because of aerosol droplet spread, which may spread 4 meters or even more, but certainly 2 meters, and rigorous and frequent hand washing. Should women be wearing masks? Well, the World Health Organization says no. The guidance in the United Kingdom is no. Interestingly, of course, there is limited, if any, evidence that standard cloth masks and even surgical masks protect you against developing or catching coronavirus, although there is evidence that it may reduce spread from infected people to you. Within the United Kingdom, the recommendation is that women in the 3rd trimester should be taking extra precautions, and that any woman who is pregnant and who also has significant heart disease should be considered to be in a very high-risk category. But on the whole, in the 3rd trimester, for instance, the recommendation from our government is that women should be considering occupational adjustments. Now, women are clearly going to be concerned about whether it's safe for them to attend antenatal appointments, and it is very important that while, if possible, appointments are carried out remotely, perhaps by telephone or video consultation, women are made aware of the importance of attending regularly for the welfare of both them and of their child. The recommendation in the United Kingdom has now moved from recommending that the population should only take vitamin D supplements of 10 micrograms a day during winter to recommending that they should take them all year round, and pregnant women and breastfeeding women are also recommended to take vitamin D supplements all year round. In the UK, the recommendation is for 10 micrograms, that's 400 international units, but of course that may be different in other countries, and certainly I fairly routinely say there's no problem for any woman of taking 800 international units a day. There are some things, of course, which do not work. And one of them, despite much publicity from a certain quarter in the USA, is ingesting bleach in any way. I think that one rather goes without saying. So, what about after birth? Those first 1,000 days, of course, start at conception, but in the first 2 years, there is a great deal of change going on. An infant will increase their weight by 5-fold, and they will gain 1 gram of brain weight every single day. So it's clearly a crucial time in infant development. Very reassuring, of course, that we have seen no evidence of teratogenicity from SARS-CoV-2. Breastfeeding is, of course, a question which is of enormous concern to every mother. Is there any transmission in breast milk? And thus far, the evidence is a pretty categorical no. Currently, there is no evidence of transmission of COVID-19 through breast milk. And overall, the recommendation of the Royal College of Obstetricians and the Royal College of Midwives is that the benefits of breastfeeding outweigh any potential risk of transmission of the virus, even if the woman is infected or suspected to be infected. So overall, there is general advice, and again, it's not rocket science. It is standard advice that, of course, we should be giving women at all times anyway. Do wash your hands before you touch your baby, before you use a breast pump, or before you touch any bottles. Do avoid coughing or sneezing on your baby while you're feeding, even if you're not known to have coronavirus, because there is now some evidence, we think possibly 2 days, where a woman is infectious, or anybody is infectious, in the pre-symptomatic stage. For babies who are bottle-fed with formula or express breast milk, not surprisingly, strict adherence to hygiene. Then, of course, there is the bigger picture, not specifically related to breastfeeding, but perhaps, can a grandparent care for the child and feed that child? And overall, the recommendation, certainly within the United Kingdom and indeed in many European countries, is one of social distancing wherever possible. Grandparents, of course, are at higher risk if they catch the virus themselves, but also, of course, if they are in another household, there is a higher risk that they might pass that virus on to their child. In terms of breastfeeding your baby, well, if you've got symptoms, again, the Royal College of Obstetricians and the Royal College of Midwives say that this is a discussion for a woman to be having with her healthcare professionals. The risks of holding the baby, but the benefits and risks of feeding choices, remembering that key point that there is no evidence that coronavirus is passed on in breast milk. It may well be worth considering wearing a fluid-resistant surgical face mask if it's available while you're feeding, if you choose to continue feeding your baby yourself. And of course, while women are expressing breast milk in hospital, they should have a dedicated breast pump set up for them. But when a breast pump is being used at home or in hospital, all the recommendations for pump cleaning should be followed after every use. And of course they should be by every woman, but perhaps even more scrupulously in this case. And I would suggest perhaps getting somebody else to clean the pump, taking all the right precautions to ensure that they do not become contaminated. It may also be worth asking if the woman would consider getting someone who is well to feed their baby with expressed milk if, and really only if, she doesn't feel comfortable or if she feels too unwell to feed that baby herself. Can babies be infected? Well, interestingly, this is a review of 72,000 cases by the Chinese Center for Disease Control, who have the earliest experience, and of those, less than 1% of cases were under 10 years old, and in this review, no deaths occurred in the group aged 9 years and younger. There was also a statistical modelling report which suggested a very good prognosis of children compared to, say, over 80s, where 25% of over 80s will have infection severe enough to require hospitalisation. Approximately 0.1% of children, according to this modelling report, require hospitalisation, and only 5% of those are ill enough to require critical care, which means that the overall case fatality rate, the mortality, is 0.002%. Hot off the press, though, I will just have one slide, just hold that thought. Those are data as of the 25th of April, and since that, something has happened. This is an example of a single case study, which I think really reflects that in babies, even if they do become ill, and this was a 3-week-old boy born at 36 weeks to a young mother who had had treatment for antenatal strep B. He had a 2-day history of nasal congestion. He had had previous suspected neonatal sepsis, but he'd had a full workup which was negative and he'd been discharged, but he was readmitted with hypotension, tachycardia, hypothermia and tachypnea. He was confirmed to have SARS-CoV-2 on that occasion. He did require ventilation, but the hypotension resolved on day 2. He was extubated on day 5, which is early compared to many older patients, and he was discharged on day 9 without needing supplemental oxygen. But although the picture overall has been very positive, I do just need to remind you that as of the 27th of April, there has been an alert sent out to all GPs in the UK and a statement from the UK Paediatric Intensive Care Society. What they say is that there has been an increased number of novel presentations of a multi-system inflammatory disease. We don't know enough about it yet, and of course in the coming weeks there will undoubtedly be much more information emerging. What we do know is that these cases are rare, but they are very severe. So there was an alert from NHS England. There had been cases of critically ill children presenting with an unusual clinical picture. This has not as yet been put in the public domain because it sounds very worrying. A combination or overlapping features of toxic shock syndrome and atypical Kawasaki disease, which of course in its typical form is very worrying. Interestingly, however, from the perspective of healthcare professionals with patients presenting, the key early symptoms appear to be abdominal pain and gastrointestinal symptoms, diarrhea and vomiting or nausea. But there was also evidence of cardiac inflammation. So there you might be looking at a patient who is tachypneic, tachycardic, and perhaps who has evidence of peripheral cyanosis or who looks pale or blotchy. So very early days yet, and we do know that things are going to be emerging. There will undoubtedly be very intense research into this and to the possible causes. But although it's worrying, obviously, it does thus far appear to be rare. There is some suggestion that there may have been similar cases in Italy and Spain, but as far as we're aware, there doesn't seem to have been any evidence raised of this in China. Are some children more at risk? Yes, undoubtedly. There's no question. Again, this was back to this big study done on 1,391 children assessed in Wuhan, and of those, only 1 died, and they already had intussusception and multi-organ failure. Of the 3 patients who required intensive care, 1 was this child with intussusception, another already had hydronephrosis, and the 3rd was a patient who was having ongoing chemotherapy for leukemia. So perhaps not surprisingly, as with every other age group, it is children who have serious underlying health problems who are at highest risk. Why do children develop severe disease, less severe disease? We don't absolutely know. We do know they do, and we know that they have fewer inflammatory markers which are markedly elevated. Lymphocytopenia appears to be relatively rare. Could it be because they're less likely to have underlying conditions? Could it be because of, needless to say, they don't smoke? Or could it be something to do with angiotensin converting enzyme 2, which is the primary entry point into cells? We don't yet know, but we do know that all these things are being investigated. Finally, a word on vitamin D. Vitamin D insufficiency is very, very common. Almost 50% of the population worldwide are either insufficient or deficient in vitamin D. Very few foods contain it, certainly not enough to provide us with what we need, and the majority of vitamin D is manufactured in the skin. Importantly, from this perspective, vitamin D receptor is expressed on immune cells, the B cells and the T cells, and it is involved in both the innate and the general, in the non-specific immune response. So deficiency is increased, interestingly, with an increase in autoimmunity, as well as an increased susceptibility to infection. For that reason, all children, I think, and adults over 1 should consider taking a daily supplement, particularly in the autumn and winter, if they're in countries where it's difficult to get enough sunshine. And the United Kingdom is most certainly one of those. If you're in a Mediterranean country, A, lucky you, and B, it may be less of an issue. But there are still going to be children and breastfeeding and pregnant women where it is an issue. Babies under 1, according to the UK recommendation, should have 8.5 to 10 micrograms in terms of supplement, unless they are taking at least 500 mils of formula every day, because that formula will be supplemented. Over the age of 1, the recommendation is for 10 micrograms a day. So our take-home messages. There is good news out there. Pregnant women are not more likely to catch it. There may be a higher risk of complications, particularly in the 3rd trimester, and particularly for women with severe or significant heart disease. But it does seem to be relatively uncommon. Standard messaging for social distancing and hand hygiene is the best protection, and the evidence for vertical transmission is slim. In terms of breast milk, reassuringly, no evidence that SARS-CoV-2 is transmitted in breast milk, but of course all women should be using standard hygiene measures. Children on the whole do seem to be less severely affected, and thus far case fatality rates appear very low, but there is this very new emerging evidence of this severe multi-system inflammatory disease. Vitamin D does play an important role in immune function, important for pregnant and breastfeeding mothers, and of course important for babies unless they are having at least 500 mils of formula a day. A whistle-stop tour, a great deal to cover, but I hope you found it useful. Thank you.
I hope you hear me. Well, Sarah, thank you so much for this wonderful presentation. And honestly, I'm really jealous. Your language skills and presentation skills are really fantastic and unique. But as I already indicated in the beginning of this webinar, you indicated there is some recent news since science is going so fast. So you have a few slides with the newest findings, info on this COVID-19. So please, before moving to the Q&A session, can you show these few slides?
Thank you very much indeed, Johan. I can indeed. And I was asked to provide one slide, but there have been so many changes in the 6 weeks since these slides were made that I think that we've got 5 changes that I'd just like to highlight, and I will do it quickly. Just to put it into perspective, I think I referred on the 26th of April to 2.5 million cases. Now been 6.5 million cases confirmed worldwide. Again, a huge underestimate, and 384,000 deaths. And since that time, in addition, in terms of symptoms, the United Kingdom has added a loss of sense of smell, anosmia, or a significant change in your taste sense of taste or smell to the symptoms. But these are a couple of the things that I think we need to think about. So BAME is a term which is used very widely in the UK, and unfortunately it's not terribly accurate from, I think, the perspective of people in other countries, but I thought it was just worth explaining that basically anyone who is non-Caucasian origin really is sort of lumped together under the term Black, Asian, minority, ethnic terminology. And it is important because we have seen significant evidence that not just across the board, but specifically in pregnancy, being a BAME origin does seem to be associated with worse outcomes in women who are pregnant, particularly in the third trimester. The other factors which have been highlighted in a recent paper include a maternal age over 35, a mother who is overweight or particularly obese. There is a distinct positive correlation between weight and the risk of severe outcomes with people with who are morbidly obese in the severely obese category, BMI over 40, being 3 times overrepresented in critical care in the most recent study that came out yesterday in the United Kingdom. Having other comorbidities, including heart disease, but again, BAME origin. And this new paper does say the association with Black, Asian, or minority ethnicities is particularly apparent. Now, indeed, it shows the previous findings. We've seen that UK BAME women had worse outcomes. Individuals admitted to intensive care were also overrepresented in terms of being a BAME origin, and that if they did get into intensive care, their outcomes were worse. Now, it's not clear, and it should be pointed out, that there are lots of other factors, and there's been huge debate. I think you can imagine it's a very hot topic politically at the moment, whether it's a socioeconomic factor, whether it's because people of BAME origin are less likely to want to access or to be able to access healthcare, or whether it's due to comorbidities. They've certainly tried to account for the increased likelihood that somebody of BAME origin will have type 2 diabetes and cardiovascular disease, and type 2 diabetes, of course, is also a significant risk factor, but just worth flagging, I think. Next slide, please. So placental pathology, this is interesting, I think, just in terms of teasing out what's happening in women who do have COVID-19. I talked earlier on about the fact that 90% of women in that one study of 108 women were delivered by cesarean section. The most recent survey that's been done across the UK, they're having a registry, and they've got 428 women on it. And of those, 59% have been delivered by cesarean section. So a significant proportion of those, though, either for maternal or fetal compromise. And in terms of fetal compromise, there is this new study where they've looked specifically at the placentas of women who had severe SARS-CoV-2, severe COVID-19, and they did show that there was a significant arteriopathy, which again goes very much with this idea that COVID-19 is not just the respiratory virus we thought it was before, that it does have significant impact on clotting. It can reduce clotting in the first place, but it can also have an impact on fibrinolysis. And we see patients with significant cardiovascular complications, and those vascular complications do appear to extend to the placenta as well. So there are some reproducible histopathological abnormalities, and that means really that we must be very careful, and I think we should be monitoring the child much more carefully in a woman who has symptoms of COVID-19 because of this risk, of course, of IUGR and fetal compromise. Next slide, please. Then transmission in breast milk. I was absolutely clear in my presentation that there was no evidence of transmission in breast milk. However, there has now been one case, one. It was a specific case where they did sequential breast milk analysis of 2 women. There were only 2 women in the study, but they looked very, very carefully at breast milk, and they found on 4 consecutive days in one of the cases evidence of coronavirus in the breast milk. So it has not been enough to cause the Royal College of Obs and Gynae. This paper came out in the middle of May, and since that time the Royal College of Obs and Gynae has not changed its guidance. It continues to state that for the vast majority of women, the benefits of breastfeeding will outweigh the risks. But I think it's just worth pointing out that we do now have at least one proven case in the literature of a woman where there did appear to be transmission of SARS-CoV-2 in breast milk. Next slide, please. I talked very briefly in the presentation about why children might be less affected, and I think increasingly we're looking at the fact that they don't appear to have any evidence of inflammation, of course, in the arteries. They don't have cardiovascular disease, and the inflammatory markers which go along with cardiovascular disease, that may have a significant effect. But this was a very interesting study, which just really more academically interesting than anything else, but it does give a biologically plausible mechanism why children should be less severely infected and indeed may get the condition less often. So this is the ACE2 gene, the angiotensin converting enzyme 2 gene. It was expressed less in the nasal epithelium. And if we go back to that idea that the virus uses this receptor, the angiotensin converting enzyme 2 receptor, in order to gain entry into cells, that does very much suggest a plausible biological mechanism why children may be less severely affected. So good news in that respect. Next slide, please. Hot off the press, this is just one last study, and this was going back to that very new finding of the multisystem inflammatory disorder in terms of children, where at the time I think there were 25 to 30 cases which have been identified. We've now got closer to 300 cases identified. However, positively, a lot of those cases that have come out since we saw this do appear to be milder, and very importantly, their outcomes continue to be good. So this was an example. It was a small study from France, but I think what was really key to hear was that although they had the typical features of conjunctivitis and persistent fever 5 days or more and generalized peripheral pain, a very high proportion of them had GI symptoms, so diarrhea and or vomiting, which we don't tend to see as much in Kawasaki disease. Also, 3/4 of them had evidence of myocarditis, which is seen in Kawasaki disease, but perhaps not to the same extent. The good news is that they all received immunoglobulin and half of them received steroids and all had a favorable outcome. But I think the really important factor here from our perspective is that 12 of them were of African ancestry. So I think it is worth just bearing in mind that, again, it may not just be the mothers who are at higher risk. It is possible that the babies are too. And then just one final advance, even more hot off the press. I found this just last night when I was looking through in terms of antibodies, because I know there's been a lot of interest in whether or not antibodies can be transmitted in breast milk. There is a new paper that suggests that there is some antibody transmission. Now, what's interesting is that one might perhaps have expected it to be IgG antibody, because IgG, of course, human milk IgG mainly comes from blood. So if you had human IgG, the mother has COVID antibodies, then we would expect them to be passed forward. However, in this case, this showed that there was significant evidence of IgA in breast milk. Now, it remains to be seen, as with adults, whether having antibodies confers immunity, but I think it is very exciting news indeed. So let's end on a high note, and time for just perhaps a couple of questions.
Okay, Sarah, so nice that you was sharing these newest data in this webinar. It's really nice, and it's going pretty fast, and it's fascinating new stuff that is coming out. So it's really great that you decided to show these slides at the end of your story. We do not have time for many questions, but again, if the questions will come in, we will forward them to you later. But there are two tiny little questions I am forwarding to you now. So with what symptom would you give specific treatment to COVID-19 positive pregnant women? And does gestational age differ in the start of the treatment?
So in terms of COVID-19, we don't use a standard treatment. Treatment is supportive, not like, say, Kawasaki disease, where all children would expect to give immunoglobulins and aspirin, and some of them might get corticosteroids. So we don't have that standard rationale for treatment. Treatment is supportive, so it would very much depend on the clinical condition. However, I think we would have a lower threshold for a woman later in the later stages of pregnancy because of the evidence of rapid deterioration. And one of the worries about coronavirus is that the clinical state can deteriorate very, very rapidly. And we think there may be not just evidence of pneumonitis and pneumonia, we think there may well, in many cases, be evidence of multiple pulmonary emboli because of an effect on the clotting cascade.
Yeah, and there is another question coming in via my private email, so that's really funny that they found me. And that is about if it's true, yeah, that there is COVID-19 present in some breast milk samples from some mothers, yeah?
Yeah.
So might there be an interaction with, for example, the human milk oligosaccharides, as explained by Maria just before you? So that it might depend on this combination whether there is an infectious risk, yes or no, for the babies drinking the milk.
I think it is entirely possible, and one of the reasons that I've listened on both occasions when Maria's given this talk with such great interest. The problem is that as yet we have 6.5 million cases worldwide and one case where we have proof of COVID-19 in the breast milk. So I think that there is going to be interest, which has arisen as a result of that. That paper in the Lancet only came out about 10 days ago. And I strongly suspect that until then, nobody was looking because nobody expected to find COVID-19, to find the virus in the breast milk. I'm quite sure that going forward, people will be looking into that. And I'm sure that oligosaccharides will be a source of great interest.
Okay, well, Sarah, thank you so much for this answer. Unfortunately, no time for more questions and answers, but we'll try to solve that later on. We had some tiny little technical issues during this webinar, so we will do our utmost best to improve next time. But again, many thanks, both of you, Sarah and Carmen, for giving these wonderful presentations and the question and answers. Thank you so much. We had two fantastic speakers from Spain / Finland and the UK. It's unique, and thank you so much for joining as let's say students. It was wonderful, and hope to see you next time in another webinar. Thank you so much, and I will close the meeting now.